So this is Alice. Alice is an 83-year-old female who arrived to our Emerge with EHS after being found on the floor of her bathroom by a neighbor who stopped by to check in. Upon arrival to the ED, it was noted that her leg was externally rotated. She was unable to weight bear, and she rated her pain at 7 out of 10 with movement. She was rubbing her hip. X-ray confirmed a displaced intertrochanteric left hip fracture. Patient stated that she had had some loose stool. Some loose stool and urgency getting to the bathroom. She is unsure of how long she was down. Her neighbor said that she saw her the day previous. She was previously an independent, well-functioning lady with a history of type 2 diabetes for about 20 years that has been well controlled, hypertension, new diarrhea. She did have a fracture of the left wrist at 72 after tripping over her dog, and a right wrist fracture at 80 with a slip on the ice. It was determined that she was fit for surgery, although she was not oriented to place or time. She was taken to the OR right from Emerge. Medications, she's on a multivite, metformin, Lipitor, and Coversol. Dr. Legay is here to review the intra-op and pre-op care provided.
There we are, great. All mic'd up. Thought we better walk around a little bit. It could be boring otherwise. Anyway, I got a note for you all. We got a problem. But there's good news and bad news. Bad news is you all miss Christmas, because outside the weather definitely is late January. The good news is if that's right, then we're going to get into spring quickly. Anyways, the story. Okay, so we're going to talk about Alice, but I'm going to do a lot of background stuff first. So hopefully this isn't going to be too up. Oh, just the down. Okay, there we go. We'll get the. So there's Alice. First of all, I'm very pleased to be here talking at this annual lecture series. Jerry was great when I came in 1992. He was the chief of surgery, and him and Dr. Cam welcomed me, and was a great colleague, and it's just too bad he left us so young. But since that time, we've had a number of good series, and supported by Diane and the foundation, and I think everybody's learned from it, and it's been very supportive. It's about the 4th or 5th time I think I presented at it. I was at the first one.
I neglected to mention that when I spoke, because it's so generous of you to do that.
Well, I'm very pleased to be here. You're welcome.
Thank you very much.
Yes, very good cause. And it's great to see everybody out. Saturday morning, early as Saturday morning, it's so cold outside, everybody's here. It's fantastic. So we got real interest. So there's Jerry. So yeah, I'm talking about the orthopedic perspective. We get called, this is a routine thing, we get called all the time. And what are we going to talk about? So here's the goals. We're going to talk about the pre-op considerations and the contraindications to surgery. We're going to spend a lot of time on that, actually. I'll briefly go over the types of hip fracture, the stuff that we do all the time that you've seen on the floor, but it might be helpful to go through it. Discuss the potential post-op complications and routine post-op care. I don't want to take too much thunder from Dr. Van Malsen, but hopefully we won't overlap too much. There's a quiz at the end, so pay attention. Pay attention. This is a CMA. We have to do some questions. So these are the questions. You're getting the questions ahead of time, so it's kind of open book. Okay, so first of all, what's the frailty scale? How quickly should patients go to the OR with hip fracture? Which type of hip fracture bleeds the most? Bleeding is important and helps with to look at our post-op care. Should patients be able to weight bear after operative fixation? Can we walk them right away? Kind of like a sports medicine thing, get up and get going. What are the major complications of pain control after hip fracture patients? So keep an eye, and we'll talk about the answers at the end. Oh, a little closer? Oh, there you go, sorry. And now this is an old slide. And when I went to prepare this talk, I said, well, I'm going to use just my old slides from the old talk, and that makes it easy, right? You know, it's all done. Because we used to do a lunchtime series, Lunch and Learn we called it. We had some support from And so I said, well, let's look at that and see when it was. And I look back and see, it was 2003. That's when we did this talk. So things have learned, we've learned some things since then. Of course, a hip fracture, actual from an orthopedic point of view, it's very similar. There's a few little techniques that are different, but we learned a lot about the management of the patient pre, and that's what we can probably concentrate on more. So 2003 is the last time we did this. So the major updates since 2003, our population is getting a lot older, it seems, and we seem to be seeing a lot more hip fractures, and the patients are a lot sicker in often cases. Frailty scale is a new thing. We always knew that people were frail, and the question was who should we operate on, who shouldn't we, and that gives us a little bit of a guidance. More patients are considered non-operative than they were in the past, although basically operation is the best thing if they're able to undergo it, if that's still but the question is it best for them or not in certain situations. In 2011, the Canada and Dr. Waddell put out the National Hip Fracture Toolkit, and this is really good, and there's been other ones that have been repeated since then. So it gives us more evidence-based data that we can really push to get these patients looked after. Because a lot of these patients would be sitting around for days and days and days. And this is one of the things that really said they got to be done quickly. So we're going to look a little bit at that. I'm not going to go through the 15 or 20 recommendations, but just a couple that I thought were important. Use of intramedullary fixation, I'll show them some pictures. It's a bit of a less invasive technique for doing the hip fracture. I think it really helps the patient. They heal much quicker with it, and early weight bearing is tolerated. So here's our patient, just to go through some of the things, but we're going to keep on. So she's previously independent as far as we know. She's got some support in the community by neighbors. We don't know if their family are involved. She's found on the floor. We don't know the timing. That can be a problem. If she's been on the floor for 24 hours, then we get into lots of other problems with even pressure sores, with the rhabdomyolysis from muscle. She could have some nerve damage depending on how she's laying. Her leg's externally rotated. That's just a clue that her hip's broken. And she's got a displaced intertrochanteric fracture. We're going to go over the types of fractures. It's important. There's basically the two types are subcapital or intercapsular fracture and extracapsular fracture. So I have an illustration on that. She's got diabetes and high blood pressure, but otherwise she's been pretty healthy. And she's had some previous fractures before. Mental status, she's oriented to person, but not to place and time. Some of that just might be the medications and the fact that she's been laying around for 24 hours without food and that kind of thing too. And she's on some medications, but not much. The things to consider is the functional status, the pre-injury functional status. So is she a walker? For her, but for everybody, is a patient a walker? Because the one thing that surgery does is help people to walk better. If they're non-walking, the surgery may not be as beneficial for them. What's her living arrangement for when she goes home? This is more for the discharge planning. What are the supports in the community? And the circumstances of her fall. Is it witnessed or unwitnessed? In this case, it's unwitnessed, so we don't know, why she fell. We think she might have fallen because maybe because she's had the diarrhea, maybe she slipped, maybe she's dehydrated. There's all those kinds of things, but some people will fall when they're having a heart attack. And then that really brings another problem when it comes to surgery. How are we going to deal with this patient from a surgical point of view? Can we operate on them? Is it going to make them, are they a candidate for surgery because they just had a heart attack? And how long? So medical status, we need to go through all these things with the patient pre-op as you would, but cardiac is really important, especially if they're going to go under surgery. You want to decide the patients that are safe enough to take to the OR so they don't die intra-op, they don't die post-op, and they get a chance. But if they're not able to go, if we just really think the risks are worse, that's the non-operative patient. So we have to look at ischemic heart disease, congestive heart failure, pacemaker. Are they in atrial fibrillation? Are they on warfarin and anticoagulation for that kind of thing? What should we do with the anticoagulation? Do we have to wait till their blood is less thin, or can we just go ahead with the surgery? That can be somewhat dependent on the type of operation you want to do and just what the type of anticoagulation is. Respiratory status, of course, if they're O2 or if they require O2 for any reason, puts them in a different category. Kidney function, do they need dialysis ahead of time or something like that? Liver failure, diabetes, and mental status. We went through that. So the standard investigations, you need to know their hemoglobin level, you need to know their platelet level, May need to give them some pre-op blood, maybe not. We don't blood transfuse people as much as we used to. 10 used to be the number. Now we're down to like 8. Although if you have a patient with a major cardiac problem, they need to have some oxygen in their system, maybe more than someone else. You may have to get it up a little higher, but 8 is the the area where you're looking at. But if a patient's been chronically anemic, then you're not as aggressive with their transfusion either, because they've already adjusted to it. Electrolytes, is her potassium low? Is that a problem? Maybe she's had diarrhea and her potassium has dropped. There's some problems there. The creatinine BUN, of course, kidney function. If she's on anticoagulants, the INR, EKG, of course, and chest x-ray to see if there's any developing pneumonias, because she's been on the floor for 24 hours maybe. Other possibilities, if you want to look at cardiac, would be the troponins. That should be hemoglobin A1C for diabetes, to see how well controlled it's been, her liver enzymes, and if she's hit her head, or if there's a patient that comes in with a fall like that, you'll have to evaluate, because she does have a problem with her orientation. So CT scan might be necessary. Not in this case necessarily. The frailty scale. So this is a way that we assess patients, and Dr. Vilmosen's the expert on this, but we've learned from them, and hopefully she'll go through some of this. But mobility is really important. So if a patient has poor mobility, they tend to get frailer. Okay, associated medical, if she had major problems in her major organs like heart, respiratory, liver, and kidney, if those organ systems have major problems, that puts you in a little different frailty level. Mental status, of course, is one of the really most important things, but it's only one of the 4. And then her need for assistance, or the need for assistance for activity of daily living. So there's been a Frailty scale developed, and this helps us to understand the patients, or how well the patient's going to do, and how they're going to do post-op. And the problem with surgery is we often drop them down a frailty, or especially from a dementia scale, we drop them down one. And so you have to see if you're actually going to help them. So this is a scale. It's not a very good slide, but I just took it. This is on our papers that we can do, or toolkit that we have in Emerge for filling out for the patient pre-op. So this is on it. So it really gives, I don't know if you can see it very well, but it goes from very little frailty, number 1, over to, as you get, so you have no functional limitations at all. You have no active disease symptoms, and you work your way up. Medical problems well controlled. They have some cardiac disease, but it's well controlled. Medical symptoms that are limiting their activity. So then we get into they can't be active. They get short of breath or something. So they're in number 4. Then number 5 needs assistance with high order or activity. So they actually need somebody to come in and help them. So you get a little bit more frail. Medical assistance with all activities, dependent personal care. But so you can see. So you get someone on this end of the scale. Are we going to actually help them? They're not mobile. They need a lot of assistance. Maybe we're going to put them at more risk with a big intervention than on the other end of the scale. If we don't get them that they can get up and around, we're going to make them worse. So we have to operate. So that's a good kind of an idea. And the other thing, you talk to the families about this too, because families are a bit confused. Does mom need her hip fixed or not, right? And some of them all want it fixed, and some of them don't want it fixed. And this way you can kind of give them some objective data and say, well, she's in this range, and she'd be better off having it fixed than not fixed. Or she's way up here, she's not getting out of bed in 10 years. This will get better, and we don't have to fix it. So that kind of helps us in that deliberation. So in general, all patients should have surgery if there's no other complications, because the problem with surgery is the stress of the procedure, the blood loss, the stress of just going under the anesthetic or whatever, the change in their mental status sometimes with an anesthetic. But the pro is that the short-term ability to move around, ability to walk, and the long-term ability to walk is way better. So that's the big pro, because if you lose your ability to ambulate, you go down on the frailty scale. So in general. So other relative contraindications of surgery, of course, cardiac status. If you have a recent MI, we try not to operate within 6 months of a recent MI. So because your risk of having a second MI or worse MI is there. Severe heart failure, pulmonary hypertension. That puts you in another level for the need for anesthesia. It's a lot harder to deal with those patients under anesthetic, so and there's other anesthetic medications needed, so that makes it a bit difficult. Severe aortic stenosis the same way. As soon as they go asleep, they drop their blood pressure. Very difficult to deal with that. Respiratory, in general, people that require high levels of oxygen for either cardiac or lung problems are going to be at a higher risk of surgery. Liver failure is bad as well, difficult for the anesthetic medications and for dealing with any of the medications we use. So that's another, if you have high, or your liver is not functioning well, your risk of surgery goes way up. Frailty index, we talked about that. Non-ambulatory patients in general, we have to be really considering, are we going to help them much? What's the difference it's going to be? In general, it helps from nursing and from mobility and from the patient's pain if they have a stable fracture, right? Even if you're not getting out of bed, but you can't move around. And if you can't move around, then you're more susceptible to blood clot, pneumonia, pressure sores, all those kinds of things, right? And then, or you have to give them so much pain medication that you knock them out so much that they're acceptable to all the same problems. So that's what you have to kind of weigh off. And severe dementia, of course, with all the. So this is if you look on the web, there's all kinds of studies about comparing operative versus non-operative treatment. And this is one from Singapore, actually. But so they compared operative patients to non-operative patients with hip fractures. And of course, there's a big bag of patients with different medical issues and that kind of thing. But in general, the overall mortality, actually, their mortality rate was really good. The overall mortality, considering both groups, was only 14% in 1 year and 24% in 2 years. Ours is probably a little higher. Generally, we talk about 30%, 25, 30%. And that just reflects the sickness of the patients. But in the non-operative patient, their 1 year mortality, if they didn't operate on them, was 30%. Which is what ours usually, but they called that 4 times what the operative patient. Their operative mortality was quite low. That's because people move. And interesting, in this study, the anesthetic level, ASA 1 or 2, they didn't make any difference in their mortality. But in general, there was, if you didn't operate, of course, the leg stays shortened and externally rotated, so they have limb deformity, and you have trouble walking with your leg shortened, externally rotated. You probably can't. Or you have to use, you can't walk, you have to use a huge lift or whatever. And so their conclusion, of course, is therefore, if possible, operate. And that's what most studies will show. So we know we should operate. And this is a national toolkit that I mentioned. And there's a number of recommendations, very good to look at, and you can see that online. It talks about, anything from the type of anesthetic to use, to the type of procedure. But I wanted to just highlight, because this has been a battle, just trying to get people to the OR, because there's always something else that needs to get in the OR more. And we're always, surgeons are always fighting about, well, I got to go first. No, you go first, that kind of thing. So, and here's the general. This is the general ranking. If someone comes in, they need to go right to the OR. They're the level, the 2 to 8 hours. That'd be like a level 1, level 2, level 3. So they do say, and with the evidence that it's 24 to 48 hours, and even now it's just been upgraded to people over 80 years old should be done within 24 hours. So that's 24 hours from the time they injured themselves, not necessarily 24 hours from the time you worked them up. So they're fairly urgent. And then people less than 80, assuming that they're a little bit healthier, they should be done within 24 to 48 hours. So we have lots of data. And this is another one. This is from the Ontario government, and same thing, all kinds of other recommendations. Again, 24 to 48 hours to get in and get that done. This is an interesting study. So, and there's a lot of things like this that we probably should be treating a little bit more aggressive if we had the resources, but you just don't have the resources. So this is a study, this is a pilot study. I think they did 60 patients. So they were doing patients within 6 hours. So a fracture comes in, somehow they get them worked up and they get to the OR within 6 hours. And then otherwise it's regular care. And they were looking at, was it beneficial and should we go further with it? So they've had here, just underlined here, with 9% or 39 patients, 30% of the patients in the auxiliary care had some post-op complication, but it was compared to 47% in the regular group. So they took this as a good reason to go ahead, and now there's a bigger study. They're trying to get, I think it's 1,500 patients into it. And I know in Halifax we were asked if we could be involved in this, but it just doesn't seem that we could be involved in that. You just can't, we don't have access to the OR like that to get someone in there in 6 hours. But it's a worldwide study, so they're looking into this to see just how short is the right number. But I think, by the time you get people worked up and get everybody evaluated and get all the, 24 hours is quite reasonable. If you can do them quicker, that's even better. And it's been my experience over the last few years in Dartmouth that the people do way better if you can get them fixed and then get them. If they lay around for 3 or 4 days, they just get sicker. And there's been some other data, which maybe you'll talk about, that if you have an older person laying in bed 1 day, it takes a number of days to then get their strength back. So the quicker, the better, I think. So we'll go back to Alice. So she was ambulatory. She lives alone. It's supposed to be alone. You always see some typos. Even when you go over it so many times, there's always still typos. She does have some supports by a neighbor. We don't know about her family. There's no care requirements. She was, it's an unwitnessed fall, maybe due to dehydration or something with this infection or whatever she's had. And we don't know how long it is. She could have secondary injury. We talked about that. We talked about a lot of this. The type 2 diabetes is controlled. She doesn't have any cardiac or respiratory problems that we're aware of. All her investigations are normal. Mental status, as far as we know, it was normal for an 87-year-old up to the time of the fall, right? She's living alone on her own, doesn't have anybody looking after her, other than somebody looking into her. So I put her down as a frailty scale number 1. Hope that's right, Dr. Van Molson. No functional limitations anyways, okay. So I thought she's a good surgical candidate, and we should get her in there within 24 hours, but we were able, and sometimes this happens, we can take them right from the emerge to the OR. Casey, it's one problem in this case, just with this, is that she probably can't consent, because although she knows who she is, she doesn't know where she is or when it is. So we need to look into some secondary provider for the consent. So generally, if she had a power of attorney, and that can sometimes slow up a case because you got to figure out who it is. Although you do have the ability in a situation like this, with it's well understood that she needs emergency care, you could go ahead without an actual consent from somebody because it's well established. But it's better for everybody. Better for the family to know what's going on. What are you doing to mom? So it's better to try to chase down the family or at least get the power of attorney. So that can be a little bit of a problem, but usually you'll find out the neighbor's aware or who it is. So, and then they say, yeah, okay, and you explain it and you go ahead. So, so type hip fracture. So, general, the one up above here is the subcapital. Underneath the head's the capital, the subcapital fracture. So that's really common, and there's displaced or undisplaced. The intertrochanteric fracture is between the greater and the lesser trochanter. So, and that's various, and that can be displaced or undisplaced. It can be multiple fragments. Sometimes we rate them as like two-part, like that would be a two-part. It's just a crack, and that's undisplaced. But then it could be a two-part that's displaced, or it could be the greater trochanter can be fractured off. Often the lesser trochanter, which is this part in here where the psoas inserts, often that's broken off. And so you just described, it makes it, from our point of view, it makes the intertrochanteric fractures bleed a lot more because there's just open bone. It's a cancellous bone. It's displaced, it'll just bleed. The patients can easily bleed a couple units into their leg with the intertrochanteric fracture or with the subtrochanteric fracture because the medullary cavity just bleeds. And it bleeds until it gets tamponaded just by the effect of the tissues around it. The subcapital fractures, let me just show you the next slide. The subcapital fractures don't bleed the same way because they're limited by the capsule. So the subcapital fractures are called intracapsular fractures. This is the capsule around, it attaches from the acetabulum down to the hip. And it's important because, well, it stops the bleeding, but also it helps us to decide what type of surgery to do. Because the capsule and the periosteum it's too bad I didn't have the periosteum that goes into the bone supplies the blood supply. So the head itself doesn't have much blood supply. You can see it's in there in the acetabulum. There's a little tiny ligament up above that can supply maybe at most 25% But it's important about the capsule and the periosteum. So if that gets broken in a displaced fracture, there's no blood supply to the head. So once the fracture, if the fracture is undisplaced or just a little crack, there's often enough blood supply to supply the head. But if that fracture gets displaced, and, then there's no blood supply to the head, so the head's probably going to die. Okay, and then you're going to end up getting collapse eventually. That may take 2 years for it to collapse, so it takes some time for it to collapse, and you get arthritis. So that helps to decide whether we should replace it. So general displaced fractures, we would replace for that reason. Okay, a younger person, if someone comes in that's young, that's the person. There's all kinds of provide, but you get a 35-year-old that's tobogganing now that we're past Christmas, and they're out tobogganing and they break their hip. We want to get them to the OR right away as quickly as possible, and that's to try to rewrite those the displacement so that the capsule's not kinked, so that the blood supply maintains. Right? It's a whole different thing. It's a different issue, but so capsule, intracapsular, extracapsular, intercapsular. The problem is that the head dies. Extracapsular, the head doesn't die. It still has blood supply, but they bleed a lot more of the extracapsular fractures. And that's you worry more about blood loss pre-op, blood loss post-op, and then I always worry about the effect of our anticoagulation. If we got somebody with a displaced intertrochanteric fracture, and we fix them, but if they still bleed a lot, if we start anticoagulating them early on, then we may just make them bleed a whole lot more, and then you get in problems there. So the risk of bleeding versus DVT and pulmonary embolism. So this just represents a non-displaced fracture on the right. On the left-hand side, they've already had an internal fixation of an intertrochanteric fracture. This is a sliding hip screw, or a DHS, dynamic hip screw, DHS. So this one here, the crack was through here. We put this screw can slide down and compress it as they walk on it. So walking on this is a good idea because it'll compress the fracture down, okay? This one here is a crack just in the subcapital area. It's lined up well enough. We think that not all the periosteum is disrupted, so we could just pin that. And you pin it just so that it doesn't fall off. If the patient's not mobile and you can't pin it, it'll probably still heal anyways. But if they stand on the leg and pivot a lot, rotate, it may fall off. So, and then if they falls off or displaces, then we'll want to do a replacement. So it takes from a simple pinning to a replacement. This is on the left-hand side. On this side here, you can see that's a displaced subcapital fracture. The bones are out of alignment. So that's when you'd be looking at. There's still some attachment there, but the head's going to die, so you're going to be looking at a replacement. This just illustrates, we did a lot, with the last talk we talked a lot more about the intraoperative things, so, but this just illustrates a couple things to illustrate here. This illustrates our hip fracture setup for a hip pinning or subcapital fracture pinning. And so we need to have this fracture table. And that brings up another thing. So we went to the foundation, 5 years ago or 6 years ago, they gave us some money for a new fracture table. We got money for a new fracture table. We've been 5 years trying to get the right way to buy it. We can't just buy it. So we've been through 2 iterations of these requests for funding and all. We've got the funding, we just can't buy the table. So we're still working on it. This table was there when I came. That's 26 years ago. So, and they had it long before that. So we're still working at it. But anyways. Little plug, but certainly the foundation has helped us as much as they can. It's just getting the purchasing group. So here on the right-hand side is a subcapital fracture that we pinned. We call it an AO pinning or just simple pinning. That's a very simple operation. We can do that now. We don't even have to open it. We can do it all just through little holes. We use the imager. We can just put the guide wires up, make sure they're in the right position, put the screw over top of it. So it's minimally invasive. You can't really do it with just local anesthetic, but you don't need a whole lot of anesthetic for this, and there's not much blood loss at all. Okay. The left-hand side, again, that's a sliding hip screw. This just illustrates the 2 things. You might wonder, well, what's the difference between a bipolar and a total hip? Well, the difference is this is a bipolar, so you have a stem down into the shaft, but on the other side, it's mobile. It's not affixed to the acetabulum. Okay, that's what. So there's motion up here. There's the shaft, the component in the stem goes into the head, but that whole thing moves, so it can still move within in the cups. The cup's not been resurfaced. A total means that the cup is resurfaced, okay? So it's a little bit more involved procedure, and you have to resurface the cup. So which one would you do? So most people, this replaced the Morris prosthesis. You probably, in the old days, we used to do the Morris prosthesis. It was just one single piece of metal from the head right down through. There wasn't much patient, you couldn't adjust it to the patient. And then if you had to go to do a revision, you had to take everything all out. So with this one, the advance with this is that the stem is the same stem you'd use for a total hip. And if you had to go back, you can just take it apart, take the head off and redo the cup and not change. You don't have to tear apart the stem. And it's much better. You can adjust the leg length. You can do a lot of adjustments on it to make it a more normal hip. So if you're gonna, that's what we normally do. It's a cost thing. The Morris prosthesis was so cheap. I mean, it was the cheapest prosthesis, right? It was the first one. It's really cheap. This gets you into the cost of a total hip because the stem is expensive. Total hips are various costs, and this is an uncemented. You can do cemented or uncemented, what you want to do. But so what we do with if you have say a 50, 60, 65, someone who's really active, they have a fall, they have a subcapital fracture that's displaced, you may want to do a total hip on them because they may wear out a bipolar. Bipolar, on the cup side, that can wear over time. So with high use, the bipolar may wear out. So you do a total hip. So you take a person who's been normally functioning, fall, and they come in, then they got to hit a total hip. They never like it as much as a person with arthritis in the hip. As a person with arthritis, they've had pain, they've been stiff, they can't walk. They really love a total hip. Total hip really makes them a lot better. But if you've been normal and then you fall, and you get this thing and it's a little clunky, you get a little groin pain, it's just not the same. So they don't quite enjoy it as much. They don't enjoy bipolar as much, for sure. The total hip, they're better. So with a really active patient, and sometimes you miss it and you have to bring them, you do a bipolar and then you have to bring them back and you don't realize they're as active. So you try to make that decision if you can, and most of the time we get it right. That's the difference between the two. How's my time here? Okay. So this is something new. This is the intermedullary fixation. It's been around for a while, but I think we're a lot more adept at putting it in. The instruments are a lot better. So we do a lot of these now. This is usually for an intertrochanteric fracture. So we can do this with minimally invasive as well. We put them we don't have to make the big slash. So with the dynamic hip screw, you have to make a big incision. You have to strip all the muscles, open it up to get the screw in and put the plate on the side. With this one, we have to make an incision, but we just do everything with we put a guide wire in, and then we don't have to make as much of an incision, so the patients aren't as painful just from the muscle. And we haven't disturbed that whole tissue envelope around the bone, so they tend to heal quicker too. So this is and for the worst, like the type 3s, type 4 intertrochanteric fractures, that's the one that's the best one to use. The sliding hip screw isn't as good. This one you can line them up almost normal and put that in. But it just takes a real good fracture table like we have. Yeah. Makes it easier. Anyways, that's probably a lot of the new stuff. This is the routine stuff. So in the recovery room, of course, we have to watch all the, be really careful, look at their recovery as far as their blood pressure, their oxygenation level, worried about hemoglobin, those kinds of things, depending on your blood loss. So all those things come into play. And it depends what their pre-existing medical condition is. Pain management's important. We're going to start with some IV, IM, and then we're going to try to get off the IV and IM if we can. Bipolar total hip, there may be a slight risk of dislocation, maybe slightly higher with a total hip than a bipolar. So bipolar's got such a big head and it's so stable, they really don't come apart, well, very often. Anyways, a total hip, again, they don't really come apart very often, but occasionally they do, and so you have to be careful with that abnormal position, especially if they flex their hip. So if you do a patient with dementia and you can't control them, they're going to flex their hip up, the total hip is probably not the best way to go. A bipolar is more stable than a total hip, so a bipolar is better. Hypothermia, this is a slide from the old side, right? This is 2003. We were already looking at hypothermia back then. It's a big thing now. We got these bear huggers that people use and everything, so hypothermia, we don't want the patients to have a lower temperature because it interferes with a lot of their metabolism, and we understand that. Bladder distension. You know, a lot of these people, we try not to give them a catheter, but most of them need it as far as I can see. They come in emergency, might as well get it, because that's going to be one of their biggest problems. If we miss the bladder distension, then we're going to have problems on the other end. If they get their bladder over distended for a few hours, then it takes you a long time to get that bladder retrained. So I'm not that worried about a catheter, but some of the official, if you look at the guidelines, they want to limit the bladder, catheter use, if at all. So then the patient goes to the floor. They have the same issues. You've got to watch your blood pressure, fluid management. A lot of these patients come in dehydrated, and you know, it's really important to rehydrate them basically for the first, but then now the effect of rehydration drops their hemoglobin too. So we check their hemoglobin, it looks like it's lower than what it really is when they get back to their normal status. But on the other hand, if you have a lot of bleeding, usually it seems like we find it in 48 hours that their hemoglobin is a lot lower than we like to. So kidney function, you got to make sure they have urine output. So that reflects, if we keep their fluid up, they'll usually have urine output unless they have some kind of major cardiac issue. That's where your Lasix comes in to use that, oxygen saturation. The other thing with the fluid is you want to get these people, if they got a stable, if the hip's been stabilized, the whole goal is to get them moving. You know, don't take them to the OR if you're not going to get them up, because you got to get them moving. That's the whole goal, is get them fixed so they're less painful. If that bone is not moving around and cracking and hurting, then they can get moving. They're going to have pain from the soft tissue, no question, but it shouldn't be as bad. You got to get them moving. And pulmonary, you really want to get their lungs moving. We used to use a lot of Vincentis spirometry and sometimes pulmonary physiotherapy. DVT prevention, of course, I like to use compression stockings. When you look at some of the guidelines, there's not a lot of good evidence that it helps, but it makes some sense. There you can use the pneumatic compression stockings. There is some value in that, apparently. And the medication, with the medication, we treat everybody with DVT prophylaxis post-op. Usually start at 40 or 24 hours post-op. If you've had a fracture, think is going to bleed a lot, you have to kind of weigh that off against what their hemoglobin is and that kind of thing. But the biggest risk, I think, I mean, if you have a patient that just can't move, or that's been on the floor for a while, then they're going to have a higher risk of a DVT. If they're up and going, see, mobility helps all these things. Helps prevent pressure sores, helps to prevent, if you get your legs moving and you get the natural pumping of the muscles, you're going to prevent DVT. Going to help with the upright posture, helps with the pulmonary function, helps with the redistribution of the blood flow in your lungs, and even just with good aeration of your lungs. So we got to get them moving. This is a terrible slide, but anyways, this is when you get further on, 72 hours. It's still pain control. So pain control, we try to use as minimal medication as you can. So early on, the first, especially for 24, they're going to need some narcotics probably, but you got to keep the level down. I think we hurt people a lot more with the narcotics than what we think if we over-sedate them. But the triple therapies come in, and that's important. So you use a simple medication like Tylenol. You have to give them to it regularly, as long as I can take it. Tylenol, an anti-inflammatory, seems to be of some help. We're not really worried about interfering with healing, especially at this stage. But an anti-inflammatory, if you can use one that doesn't cause the platelets to be altered, it might be good. And then narcotic, as soon as you can, try to switch them to an oral narcotic. Over-sedation generally decreases their mobility, decreases the risk of aspiration pneumonia, changes their mental status. You're going to talk about that later. So I say the goal is to keep the patient alert, keep them upright, and keep them mobile. The floor is the same thing here. This helps with all their issues. So 72 hours, you're looking, in some of the patients you're looking at possibly discharge, but they need to have mobility. This is where physiotherapy comes in. They need to be able to look after their own bathing needs or have help with that, meals and bladder function. This gets into all the stuff that I'm not good at. Where we need everybody's help, right? You know.
Good job.
Yeah. Well, we need everybody's help to get these people back to their normal functioning. I can fix their hip, but that's all I can do. So Other things, urinary tract infection, that's why we want to try to get that catheter out as soon as possible, or if we can. The nice thing with the bladder scans now, you could use that more frequently and make sure and try not to catheterize them, or just do the in-out catheter. But a urinary tract infection could be a problem, so we have to try to get the Foley out early, as long as they're going to be able to not have distension. Bone care, compression stocks, all this kind of stuff, the long-term mobility. Questions? Oh, am I finished here? I think I'm almost done. You guys, okay. Questions? What is the frailty scale? So how are we going to, are they supposed to, huh? Yell it out? Okay, we weren't able to get the monitor thing, so you have to say, so is it a scale to measure legal CBD oil? Is it a clinical measure of fitness and frailty in the elderly? Measure of bone density. What is it? B, yes. Frailty in the elderly. So that helps us to decide what to do. How quickly should, there you go again. Huh. That's because I do a lot of shoulders, I guess. I didn't see that. I just noticed that now. Wow. How quickly should patients go to the OR with hip fracture? Hey, okay, good. Jeez, you guys are great. Everybody's awake. Wow. But these are other things, like, some people think it really doesn't make a difference, and then, they can wait till the weekend, the OR is open. No, you got to get them done. Within 24 hours, and the new recommendations is for those over 80 and within 48 for under 80, but as soon as you can is best. Which type of hip fracture bleeds the most? Good, you got it. Yeah. Intertrochanteric and subtrochanteric fractures. There was a little trick in that. Undisplaced fractures bleed more than undisplaced fractures. The undisplaced bleed less. So good for you. Should patient be able to weight bear on their fractured hip after the operative fixation? Yeah, they would. I was going to put yes, maybe, but basically it's a yes. Our goal as surgeons should be to get them stable so that they can weight bear. And the fixations are such that weight bearing actually should help it. So yes, if it's not done, then we probably haven't done a good job. Or maybe the bones have been that bad. I will say that. Sometimes the bone's really bad. So what are the major complications of pain control in a hip fracture patient? Is it over-sedation? Is it aspiration pneumonia? Limited mobility or activity, or constipation? All the above, yeah. I didn't talk about constipation, but it is. Anyways, that's my presentation, and I really enjoyed it, and hopefully it was good, and enjoy the rest of the story. Thank you. No, we have time for questions?